We've been going through the development of the GI tract, and we learned this particular GI tube largely have developed from this particular developmental remnant or developmental tissue. We call them as yolk sac, which partly incorporated into forming this primitive gut tube. And this particular primitive gut tube can be divided of three segments: foregut, midgut, and hindgut, depending on how much this particular gut tube is placed in. So, we have been talking about the development of these foregut tubes derivatives, which develops from this particular foregut derivatives into here this stomach, esophagus, and this particular coils of the small intestine and this particular gallbladder. We are going to talk about the bile duct, pancreas, etc., etc. This part we have been talking through. So, we talked so far about development of the liver, and we finish this particular development of the liver and then proceed to the development of the gallbladder and subsequent part as well. So, this much we have learned that liver develops from this particular bud, we call them as liver bud, which grows into this particular mesenchymal tissue, we call them as septum transversum. This particular septum transversum is disintegrated or modified by the developing liver bud into this particular growing tissues, and eventually this particular liver transforms this particular the content of this particular septum transversum, like blood vessels, whatever the things are going through, into its own architecture system, like sinusoids, capsules, and these particular hepatic cells and defense cells, etc., etc. That's what we have learned through. Now, we are just going to magnify this particular point about this particular gallbladder development, but before that we just want to magnify this particular point where from this particular liver is growing on. So, this is the primitive gut tube where stomach ends, and this is the lowest most part of the developing foregut tube. Now, we call them as caudal part of primitive foregut tube, which is related to the foregut tube. Now, this particular caudal most part or the lowest most portions over here where from this particular liver bud is growing from the endodermal growth, we call them as liver bud. Now, this connection which is existing between the growing liver bud and this particular primitive foregut tube, which is colored here in green here. So, this narrow channel which is communicating the primitive foregut tube with this liver bud, this finally eventually matures into bile duct. So, that particular bile duct which is bringing the bile from this right and left liver, we call them as hepatic bile duct. Now, what happens with this particular bile duct eventually afterwards, as this particular liver bud is growing on into this particular septum transversum, there is a new thing that comes to develop over here, which is a bulging over here. So, this bulging which is developing from this particular primitive bile duct, we call them as cystic diverticulum. So, this cystic diverticulum is the word that you have to keep in mind, and you can just understand this particular cystic word related to the gallbladder. So, this cystic diverticulum is just like this liver bud outpouches from this connection of the liver bud and primitive gut tube, which is going to become the bile duct. So, this cystic diverticulum eventually becomes two elements. One is the gallbladder itself, other is the connections of the gallbladder. That means, the gallbladder comes out with this particular outlet which is known as cystic duct system. So, the gallbladder is having two parts. One is having the fundus body and the neck, which is going to develop, and as well as the outflow or inflow of this bile duct of this gallbladder, which is known as cystic duct, that is formed from this cystic diverticulum. So, this is what we are going to talk about. So, this bile duct give rise to this particular ventral outpouch, we call them as cystic diverticulum. This cystic diverticulum can be divided into two parts. Distal part, which becomes the gallbladder itself, that means fundus body and the neck part of the gallbladder, and then this proximal part where this connection remains becomes this cystic duct. Now, these are two things that you have to keep in mind related to the MCQs, because these are the MCQs where they point over here the cystic diverticulum proximal part and the distal part, which develops or transforms into which embryological structures likewise. So, they want to know basically the development of the gallbladder, which includes the body, which includes the fundus and this neck, develops from the distal part of this diverticulum, and this proximal part makes this particular cystic duct only, which joins with this particular hepatic bile duct to form common bile duct. The common bile duct eventually drains into this duodenum, which is the second part of where it is opening into. So, this is about only thing about the development of this gallbladder that you have to keep in mind. Relatively easy, do not have any head bang, only this word you have to keep in mind, cystic diverticulum, that has the distal and the proximal part, that what you have to know. But other than this, the gallbladder is prone to have anomalies. What are the different anomalies can have? The gallbladder which you seeing here, which is developing from cystic diverticulum, is anomalous, and that is why this particular anomaly of this gallbladder are plentifully found. What are the common anomalies that we have to know? This is related to the cystic diverticulum formations are there. One is that intrahepatic gallbladder. That means this particular cystic diverticulum grows into the liver bud and becomes a part of this growing liver tissue and becomes intrahepatic gallbladder. This is one thing can happen. That means gallbladder is completely embedded within this liver tissue. Second thing is the growth of the cystic diverticulum is delayed. While this liver bud is growing, the cystic diverticulum should grow together, more or less simultaneously. But sometimes the growth of the cystic diverticulum may be lagging, may be delayed. That leads to floating gallbladder. That means once the liver everything is formed, this gallbladder starts to develop, and eventually the gallbladder fossa remains empty and holding this particular gallbladder floating with the mesenteric floor, which is known as floating gallbladder. These are the two things which are commonly happens in case of the gallbladder anomaly itself, which is troublesome for surgery. Why this is troublesome for a surgery? For example, you have a stone formed within the gallbladder that is present within this liver tissue. That means you have to remove the gallbladder cutting through the liver tissue, which is a problem. Second thing, if you have a floating gallbladder, it can float to anywhere, it can move to any points. It can be wrapped on transverse colon, transverse mesocolon, etc., etc. So, these are the hazards during surgery if you have these two types of anomalies. Other problems with this gallbladder problem, the duct system which is going to form here, these connections becomes the ducts. So, if the ducts, if it is falsely formed, that can create a problem. We call them as atresias or an atresia of the biliary system. What could be the atresias? Atresias means it may be have a partial absorptions of these ducts. That means gallbladder is formed, hepatic ducts is formed, then beyond that nothing is there. So, the bile may not be leaking in, but bile is not going to come. So, these are kind of atresia of bile duct. It may have a complete atresia of the external system or extrahepatic atresias or atresia of the hepatic ducts itself. So, depending on how much it is atretic or how much it is not developed, that can lead to the problem itself. So, these are the different types of common abnormalities related to the gallbladders. So, and as well as the duct system, this is what you have to keep in mind. So, coming back once again along with the liver development, this particular diverticulum which grows from this bile duct developing, we call them a cystic diverticulum which grows into gallbladder. That is what we have to keep in mind related to the gallbladder development, proximal part and distal part, and the anomalies floating and intrahepatic gallbladder. These are the two entities. Out of this you have to keep in mind. And atresia, what do you mean by atresia? Congenital atresia, of course we are referring here. So, these atresias that we have to keep in mind whenever you are dealing with these errors of the duct system. Now, moving from this important organ that we have to learn today is the pancreas development, and the development error of the pancreas, that what we have to learn. So, this pancreas, the gross anatomy of the pancreas, we know that this has been divided into few parts. We have the head of the pancreas, then we have the neck, then we have the body, and then we have the tail. Tail is related to the spleen and head is related to the duodenum, which is present to this curvatures into it. So, these parts of this particular head which has a hook like process, we call them as uncinate process. So, whenever we are going to talk about the development of the gallbladder, we split this particular development of the pancreas, we go to talk about the development of pancreas into two halves. Lower half of the body with the uncinate process, upper half of the body with this rest of this particular pancreas that we are going to talk and going to discuss about. Again, The development of the pancreas is simple, that we have to understand in just little detail of it. So, as we see that this particular caudalmost part of the primitive gut tube, where we see that this particular cystic bud is going on or cystic diverticulum is going on, little below to that we have two other out pouches or buds there or projections there. One is on the anterior body wall side, one is on the posterior body wall side. They are projecting into two mesenteries. We call them as the ventral pancreatic bud, which is marked over here in blue. Other is known as dorsal pancreatic bud, which is marked here in red. So, these are the two buds that are growing below this developing cystic bud or cystic diverticulum. They are projected into the mesentery lying here. We call them as ventral mesentery, dorsal mesentery, and they grow into these mesenteries. This is how the development of the pancreas goes here. So, it develops from these projections. We call them as pancreatic buds. How many of them? Two, V and D. So, ventral and a dorsal, where they are present in the mesentery respectively, ventral mesentery, dorsal mesentery, and they grow into it. Now, the next thing happens with this progression of the time. So, we have learned that this part develops into the stomach and the duodenum, which is below the part which is lying to it. Now, this particular stomach, as these things are growing on, it makes a rotation. We call them as longitudinal rotations of the stomach, which happens to take place around the longitudinal axis and the 90-degree clockwise. Now, as the stomach is moving clockwise, this swings around, this rotations of the stomach creates this particular motion onto this particular pancreatic bud as well. So, with this movement of the stomach, this ventral pancreatic bud swings below and goes under to developing dorsal pancreatic bud. So, initially one is in the anterior plane, other is on the posterior plane. As the stomach is rolling or making a longitudinal movement, this ventral one swings below and under the dorsal pancreatic bud. So, they move to the same side, they change the sides and eventually move to the same side. So, this was there, picture A, they are growing, picture B, little bit growing more, and then with this movement of the stomach, they swing to this side. So, from this side they are moving back to this side with the rotations of the stomach. So, this ventral one, the green one, goes to under to the red one, posterior to it and under to it. So, now both the ventral and the dorsal are on the posterior side. Now, what happens after that? These two guys comes too close together, becomes very sticky, joins together, becomes a single pancreatic bud. So, this V1 was anterior, then it swings, reaches under to it and they fuse together. So, this ventral and the dorsal pancreatic bud, both of them moves to a same side, joins together, makes a single pancreatic bud. That is why this story begins like this and they becomes this. Now, here comes the story what we had started with. Now, pancreas is divided into these four segments like head, neck, body and the tail. And the head can be divided into the upper half and the lower half of the head. The lower half of the head have a projection like this, we call them as uncinate process. So, this uncinate process which looks like a hook along with the lower part of the body, this much only in parfel, they are developed from ventral pancreatic bud. And rest of this thing which is left over, this green one is developed from the dorsal pancreatic bud. So, all the enormity is disproportionate growth of this bud happens because of the switching movement happens here. So, this particular ventral one contributes a less amount of this pancreatic tissue development. So, this particular ventral pancreatic bud only forms the ventral one only forms the uncinate process and the lower part of this head of this pancreas, and the red one which was originally placed on the dorsal side, which takes all the load in development of the pancreas. It forms the upper part of the body, upper part of the head, neck, tail, everything. So this is your MCQs about this particular formations of the pancreatic bud. So pancreatic bud dorsal one transforms into what are the parts, like they will be giving the choices. You know what the choices they are putting: upper part of the head, lower part of the head, neck, body, tail, except one or except one. So this is what you have to keep in mind related to the pancreas development and the fate of the dorsal and the ventral pancreatic buds. This is what we have to learn. Now, moving to the clinical problems which is related to the pancreas. Now, what we talked about, there are two buds are there, ventral one and a dorsal pancreatic bud. Now, accidentally, by any chance, if the ventral pancreatic bud instead of one becomes two, then we have a clinical condition. So, what I am saying, we have one ventral pancreatic bud, one dorsal pancreatic bud. What I am saying, by any chance, by developmental error, we have only one dorsal pancreatic bud, but two ventral pancreatic bud. So this small one, the green one, is 2 in number, the red one is 1. So what happens in this case? When this particular pancreas becomes 2 ventrally, 1 and 2 like this, and this one is posterior one, this one, and this one is going to make a swing. So when this particular thing is happening, because of the rotation here, one of them is making a rotation clockwise, other one is making a rotation anti-clockwise, resulting in encircling over here like this. So picture A and picture B, they are making a rotation now. The ventral one going to make a move to the posterior and down. One of this ventral one is going clockwise in rotation, other one is going backwards or anti-clockwise rotation, and encircling in the developing primitive foregut tube. So what is happening here? The pancreatic tissue is encircling on this developing primitive foregut tube. Now what this primitive foregut tube is going to form? The duodenum. So they are encircling around the duodenum. That means they are compressing or choking the duodenum, which is developing here. So what happens over here? This duodenum is compressed. As a result on this, there is a compression of duodenum, so that lumen of the duodenum is narrowed. So what happens if the person is born with this kind of error? The food material can cause the esophagus going well, going to the stomach going well, then going to the first part of the duodenum, fine. Then they are moving down to the second part of the duodenum, they are arrested there because the lumen is narrow. So there is an obstruction in the duodenum. So beyond that part, food material is not moving fast, resulting in the patient has a difficulty in swallowing. Who are the patient? Newborns. They are taking foods for some time. After 1 or 2 hours, they are throwing away all the products. So it is taking little time, but eventually they are regurgitating, they are vomiting out. What they are vomiting out? Food material. Food material mixed with the stomach content, food material mixed with this content which is coming from the bile ducts. So they are mixed up with this particular bile, mixed up with the stomach juice, everything throwing out. So this is a clinical condition that is happening, and this kind of clinical problem which is happening because of this bifid ventral pancreatic bud which is encircling around the developing duodenum, we call them as annular pancreas. So this annular pancreas is your exam short note, ANNULAR. Annular pancreas is a condition that you have to explain embryologically why this is happening, why there is an obstruction to the individual who are having this kind of problem. So it's a short note. What kind of error you having with this problem? We have a problem which is ventral pancreatic bud to start with. Ventral pancreatic bud is having 2 instead of 1. What happens with this particular 2? Whenever there are a rotation of the stomach and duodenum taking place, one is moving clockwise, other is moving anti-clockwise, encircling around second part of the duodenum, compressing the duodenum, and blah blah blah. So this is what they are coming with. Annular pancreas has been one of the high short notes that we've been seeing in the development era, just like hypertrophic pyrotic stenosis that we have talked here. This is another type of embryological narrowing or embryological stenosis that commonly affects the young individual. The difference between this hypertrophic narrowing of the pyrolus with this particular narrowing around this particular duodenum, the color of the vomitus. The color of the vomitus in case of the hypertrophic pyrolic stenosis was non-bilious, and this one is bilious. That means it's mixed up with the bile, other one is not mixed up with the bile. Before the bile can get in, the food material was thrown out. Here we have the food material is getting mixed up with the biles because this obstruction is little bit narrowed down beyond this particular point, and this is coming up. So this is one of the problem of this pancreas. It has other problems of the pancreas. We call them as accessory pancreatic tissue. That means pancreatic tissues is present in the pancreas. If the pancreatic tissue is present elsewhere other than pancreas, we call them as accessory pancreatic tissues. Where it could be? It could be in stomach. It could be in diverticulum. We call them as Meckel's diverticulum. We'll talk about the Meckel's diverticulum in subsequent sessions. So this is what you have to keep in mind related to the clinical problem. You land up in surgery, you will see this particular problem coming up. Pancreatic tissue, which is extra present, we call them as accessory pancreatic tissue, which is present in two common sites, stomach and Meckel's diverticulum. Then what happens? This particular stomach produces pancreatic juices. They should be producing these gastric juices. Instead of making only gastric juices, they are making this particular pancreatic juices as well. Meckel's diverticulum, they are producing some kind of tissue element or secretions which is related to the pancreas as well. So these are the clinical problems that we call them as accessory pancreatic tissues. So these are the two things related to this particular development of the pancreas. So again, pancreas is two of them to start with, becomes one, ventral and dorsal bud. Ventral one changes its mind, moves to the posterior side, becomes close to dorsal one, fuses, becomes one, and they contribute to form whole of this pancreas. Everything on the pancreas except this particular part, which is formed from ventral pancreatic bud. Uncinate process, uncinate means hook. They are lying on lower part of the pancreatic head. So head of the pancreas at the lower part, and the uncinate process is coming from this blue one. Rest is the red one. And if by any chance, instead of being one ventral pancreatic bud, it becomes two, it can swing around, choke around this particular developing duodenum and create an obstruction. We call them as annular pancreas. So this is what we have to keep in mind. So that's what we have covered, this particular content of the primitive foregut tube. So that particular picture that we have started with, again we are moving to. So this is what we have finished here, foregut tube. Up to this midgut we have seen. So starting from this esophagus, stomach, and this part of the duodenum, liver, pancreas, and as well as gallbladder and the duct system and spleen as well, which is not part of course of the GI tube, is developing from here. Now we are moving into the next domain, which is the midgut tube. That means which is connected to this particular yolk sac tube through this connection channel. This connecting channel we call them as vitalo-intestinal duct. Now this channel should not be present beyond 6 weeks, 7 weeks, 8 weeks, 10 weeks. So if it is present beyond that, we have a trouble. That's what we are going to learn. So this midgut tube is going to bring or going to make what? So from this segment to the hindgut segment, which is connected to this particular yolk sac, we call them as midgut tube. So what midgut tube forms here is magnified here or developed here. So this midgut tube makes this particular tube like this, and this particular tube we call them as primary intestinal loop. So it looks like a U-shaped loop, it's called as loop. So this midgut tube looks like this after some time, like 5th week of life, and eventually becomes what? So this midgut tube becomes lower part of the duodenum, jejunum, ileum, cecum, appendix, ascending colon, transverse colon, up to the junction of this distal and the proximal 2/3. So that means pretty much everything of this particular coils of the intestine is developing from this particular midgut tube. So this is what we are going to talk, and we are going to talk about the development of the duodenum. So this is what is prone to have most of the anomalies in our body. So this duodenum, anatomically in the gross, we divide into 4 parts, part 1, part 2, part 3, part 4, likewise. Developmentally, we divide the duodenum into 2 parts. before the opening of the ampulla of Vater and after the opening of ampulla of Vater. What do you mean by the ampulla of Vater? The duct of the pancreas, we call them as pancreatic duct, the outlet of this particular common bile duct, which joins together and opens into the duodenum. So this is what is happening here. The duodenum, which looks like C-shaped structure, which eventually curls back like this, can be divided into two halves embryologically. So this is upper half and this is lower half, segmented or divided by this particular duct system. We call them as ampulla of Vater. So what is ampulla of Vater? Which have the communication or this duct channel receiving of the pancreatic duct and common bile duct. So common bile duct comes from the gallbladder and this stomach and this liver, which is carrying this bile, and the pancreatic duct carrying this particular secretions from the pancreas. They are opening together into this particular duodenum. We call them as major duodenal papilla at that point, which basically separates between the part of the duodenum first and second. So this duodenum developmentally divided into two halves, above the opening of the pancreatic or hepatopancreatic duct and below the opening of hepatopancreatic duct. So this above the opening of the hepatopancreatic duct is developed from the caudal part of the foregut, that means lowest part of the foregut tube, and this part which is formed by below this opening formed by the cranial most part or head-most part of this primitive midgut tube. So this midgut tube and foregut tube has a junction here. So this is where the trouble begins. Why this particular troublesome point? That midgut tube and this particular foregut tube has a common interaction point, and often where the two people works is the point where their maximum error happens. What error can happen? The most common error happens over here. We call them as vascular problem. What do you mean by vascular problem? That means the foregut should be receiving blood flow from this blood system which is coming from the celiac trunk. So all the derivatives which is developing from this particular foregut tube should receive the blood from the celiac trunk or branch of it, whereas this particular midgut should receive the blood from the superior mesenteric artery, and here lies the conflict. So this particular junction, they thinks like he will supply it, and other one thinks no, it's he will be supplying. So this particular problem leads to a common problem into this particular junction area. We call them as vascular accidents. So that some parts is left with no blood supply, that can happen. That is a common mistake or common problem of this duodenum that happens. So this development of the duodenum, which you coming over here, that we have to keep in mind related to the two simple points: above the opening, below the opening, cranial most part and the caudal most part, the foregut and midgut, they are supplying. This is what we have to know. That's it. If you remember, that's fine. But the problems related to it, we have to keep in mind related to the developmental error of this foregut tube. That means clinical problem of the foregut tube that we have to keep in mind. What are the problems that arises of this particular foregut tube error? That we call them as gut atresias. This is the most deadliest complication that we have. That means a part of this particular gut tube is not formed. That means that commonly happens. That means the upper part of the duodenum is atretic. That means this part is not formed, upper part, the lower part is formed. So we call them as upper duodenal atresia. The reverse thing can also happen. The upper part is normally formed, the lower part is atretic. That means lower duodenal atresia. These are the two common problems that can happen. Why this problem happens? Because we call them as vascular accident. That means lack of blood supply. Now what happens if you have atresia? The same thing. Obstruction. Food material cannot pass. That gives the clinical problem of the atresia. They are taking the foods, after a while they are regurgitating, throwing it out on the first day of life. That should arise the suspicion of something is not happening properly in case of this passage or food passage likewise. So, these are the two things related to this particular gut atresia that you have to keep in mind. See that this part A and B, you are supplied by blood vessels. This one is properly formed, this part is not. So, this part should be developed from or should be given the blood supply from the other source. That means superior mesenteric artery should be supplying, where this one is supplied by the celiac trunk. This is getting proper blood supply. This one is unhealthy or poorly formed. They are leading to formation of atresia. Compared to the B1, you see that this particular B1 picture is also there. It leads to a part which is thready. Initially, there was a blood supply. Then there is lack of blood supply. So, it is partially formed, partially atretic. Likewise, the reverse thing can happen as well to this particular vascular problems. So, this particular atresia which is happening like because of the lack of blood supply. Second problem, this tubes is properly formed, but they are not a hollow tube. That means they are not canalized. So, there is a tube which is formed that need to be canalized or vacuumed out. So, this vacuuming is not done. So, this apoptosis or this vacuuming part is not properly formed. It becomes or remains as a solid tube. So, this particular duodenum is there formed, but it is a solid tube. No cavity, no lumen inside. So, that particular problem we call them as lack of canalization, or this particular problem having a solid duodenal tubes. So, this particular problem we call them as vascular accident that commonly happens because of the vascular error or blood supply errors affecting this part of the gut. Which part of the gut? Duodenum. So, duodenum is the part of the intestine which is having a highest incidence of the malproblems or malformations or the GI malformations that we have to keep in mind. So, going back to this particular original thing where we had started to. So, this is the interesting part of the GI system development we are just going to talk. So, this is what developmental thing we started with the midgut tube, development of the duodenum, which sourced from two different sources, and the common problem happening here, which is known as atresia or this canalization problem, that is because of the vascular accidents. And the incidence of this vascular accidents is the highest GI error that is we are dealing with. Next thing is developing of the midgut tube. That means everything beyond the duodenum. That means the jejunum, ileum, cecum, appendix, colon, ascending, transverse. That's what we are going to talk about. So, all parts of this particular GI tube that develops from a tube like this. So, you have this particular foregut form, the stomach, then duodenum, and beyond this particular duodenum there is a loop. So, this loop which looks like a U. So, this loop we call them as primary intestinal loop. In short, we call them as PIL. That is what you have to keep in mind. So, this particular PIL, you see that is pierced or accessed by an artery. This artery is a SMA, superior mesenteric artery, which gives to supply these branches to it and supplying to it. So, this intestinal loop pretty much gives rise to all the coils of intestine that we have. That is what we are going to talk. This is the most interesting phenomenon that we come across in the GI tube formation. So, we talk about the PIL or development of the PIL. So, if you look at this particular PIL, it looks like having a loop which is looking like a U. Now, you split this particular U into two limbs. This is an upper limb, this is a lower limb. We call them as cephalic limb of this PIL and the caudal limb of PIL, and it is pierced by or separated by this middle passing axis of it, which is known as superior mesenteric artery. So, superior mesenteric artery basically bisecting this PIL into upper half and lower half. That is it. Out of this upper half and the lower half, you have an anchorage point. You see this particular point, we call them as vitelline duct, where you have a bulge over here. This is the future cecum area. So, this is where the cecum develops, and this cranial limb and the caudal limb give rise to this particular coils of the small intestine and coils of the large intestine. Now, the growth of this cephalic PIL is more than that of caudal PIL. That means, this limb grows faster than that of the lower limb or caudal limb. So, this is the basic thing that we have to keep in mind. Now, what happens over here, this is what we are going to talk. So this cephalic limb or cranial limb, which is moving upwards, this is upside, this is downside. So this cephalic limb gives to rise what? The distal end of the duodenum, the jejunum, the parts of the ileum. Then we have the lower part, which is having this particular cecum and appendix, which is tagged here, and then we have this particular colon, ascending colon, then you have the transverse colon developed from this caudal limb. So this is how this whole thing is developing. We do not have to memorize all the detail of it. Right now, to understand the next part, that we have to understand into this part. Now this is an interesting part that is going to happen. You pay attention, it's fine. If you do not pay attention, reading books, you cannot make it out. Alright? So here is the story. When this PIL or primary intestinal loop is developing, the gut was a very scanty or less space. That means the space inside this abdominal cavity is less. Why less? We have liver growing, we have kidney growing, we have this other thing which is other organs is growing too. And this anterior-posterior diameter and as well as longitudinal diameter was less. So in nutshell, when this PIL tube or primary intestinal loop was there, initially at the 6th week of life, we have very less space to accommodate. But this particular tube is growing to have 11 feet length. You imagine this particular coils which is uncoiling at 11 feet. So that much of thing is going to get. So this thing starts to develop around the life of 6 week. So 6 week, this PIL was there like this. We started the journey, and by 10 week, we need to have 11 feet. So we started with 6 inches and end up in 11 feet by 4 weeks of life. You understand how fast they are going in 4 months, just like you are preparing in 9 months writing the exam, or less than how many months are left with? 6 months or less than that. So you are writing the final exam. So you know how much time you are left with. So this is how they are growing, the PIL, fast, really fast. Now, it don't have enough space. What do they do? So they need to grow from 6 inches to 11 feet and they don't have any space. So what do? They outsource. They leave the house, go outside, find a next house, grow there and come back. So this is the story. So this primary intestinal loop, they have to grow, they don't have find a space, so they move out to a different space. So this is, we call them as herniation. So this particular primary intestinal loop, they don't find any space there, they move out over there. So where they do move out, they expand towards this particular other part through this particular opening, they go to the umbilical cord region. And reaching to the umbilical cord region, they enter to that particular space and they find the space which is less occupied and they grow there. So all the PIL that we are seeing here is growing faster and moves out here, goes elsewhere. Where they do go? They go to the umbilical cord. That umbilical cord had the space at that time. So they grow there from the period 6 week to 10 week. So all this primary intestinal loop grow there, reaching to that point. So this particular phenomenon, we call them as physiological herniation. Now why do you call them as physiological? Because this happens to every individual. This is a survival thing. This is one. Second thing, this is temporary. That means it is a short-term, short-lived thing. It is required, that's why they are going, but they need to come back. So what these things is happening during the 6th week of life, they move out of the house, go to elsewhere. Where they do go? They go to this umbilical cord, grow there till 10 week of time. So once this 10 week of time is there, they achieve 11 feet length. By that time, the growth of the liver has stopped, movement of the stomach has stopped, it has growing of all organ has stopped. Now this particular anterior abdominal wall is growing in length and have more space inside abdominal cavity. So in 6th week of life, they don't have any space. 10th week of life, they have space in the abdominal cavity. So this loop, they have formed their umbilical cord, they move back to this anterior abdominal wall to this particular region. We call them as abdominal cavity. So during 6th week of life, there was a movement outside from the abdominal cavity. Then 10th week of life, they are taking it back. So there is a reverse thing which is happening. So this is happening during a tenure between the 6th week of 10 week of life. This particular herniations of the primary intestinal loop is happening in a period where everything goes in a way for the developmental purpose. We call them as physiological herniation of midgut loop. So this physiological herniation of loop or midgut loop comes as a short note for a preparation that you have to keep. So this particular phenomenon of physiological herniation of midgut loop comes with a movement. So when they move out, they make a 90-degree rotation anti-clockwise. So what happens? So they are moving out. When they move out, they make a rotation. That particular rotation is 90-degree and directions of the rotation is anti-clockwise. And when they are regressing, moving back to this abdominal cavity, there is another rotation there. There is twice a rotation, 180-degree anti-clockwise rotation. So you have to follow this particular element. So rotation of this PIL is happening when they go out at the same time when they are moving back. So together if you join that 90 plus 180, that makes a 270-degree anti-clockwise rotation together, going out and coming back. Getting it or not? So during the herniation, as they move out, they make a rotation of the PIL. How much? 90-degree. To which direction? Anti-clockwise. When they are regressing back, when 10 week of life, where they are coming back? They are coming back from the umbilical cord to the abdominal cavity. How much it is? Twice the 90. That means 180-degree. Which direction? The same, anti-clockwise. So if you join this total movement, going in and coming out, 90 plus 180, they make a 270-degree anti-clockwise rotation. So this particular rotation, to which direction, that we have to keep in mind, which is happening here in the physiological herniation. Now, the second entity of this particular part or last entity. So when they move out, they move free. The primary intestinal loop moving out, they are going free. When they are getting back, there are two set of rules are there. What set of rule? Part of this intestine that is getting back first, they should be settled to the left side. So whoever this primary intestinal loop which has been become like jejunum, ileum, colon, whoever gets back first, they will be settling down to the left side of the abdominal cavity. So if you take this particular abdominal cavity which is like this, so whoever is getting back should be taken to the left quadrant. So number one roll number should be going to the left side, and whoever getting back last should be settling down to the rightmost quadrant. This is the rule that is need to be followed. If this particular rule is not obeyed, we have trouble, we have problem. So this is what we have to remember. So once again, physiological herniation. What is physiological herniation? It's a movement of the primary intestinal loop which goes to form the tube which is starting from the duodenum, jejunum, ileum, cecum, appendix, colon, ascending transverse to third. They develop from what? PIL. How many limbs it has? Two. Cephalic, caudal. How they are dissected? By the axis, by SMA, superior mesenteric artery. Blood supply is coming from it and they are making an access to it. Now this particular PIL needs to develop, grow in a faster speed, which it cannot be accommodated at that 6th week of life inside the abdominal cavity. For that reason, this PIL has to move out of the abdominal cavity into the umbilical cord. So, from 6 week to 10 week, it grows within this umbilical cord. Grows into what? That parts of the intestine, duodenum, jejunum, ileum, etc., etc. So, 10 week of life, it reaches, it gets a call back. That means it can come back. Why it can come back? It has rooms inside the abdominal cavity. So, inside the abdominal cavity, everything is roomy now. So, once this get back and going out, they are making some rotations. When they are going out, they are making a movement. We call them as anti-clockwise 90-degree rotation. When they are coming back, they are making another movement, twice the first one, 180-degree anti-clockwise rotation. So, directions remains the same, and if you club them together, we get the 270-degree anti-clockwise rotation. Now, when they get back, they have a rules to follow. So, whoever gets back first, they will be settled down to the left side of the abdominal cavity, and whoever gets back last, they will be settling down to the right side or more to the right side. As a person, home rule maker, they make a rule, they prefer the jejunum to return first. Which column in this time? Jejunum to return first, and makes a rule that cecum should return last. They are watchdog. So, that is why they are followed. So, this jejunum settles down to the left upper quadrant of the left side, where the cecum is in the right iliac fossa. So, this rule need to be followed regard to this physiological herniation and the coming back of it. So, this is what we are talking here, rotation of the midgut loop 90-degree anti-clockwise when they are going out. When they are coming back, they swing twice. How much? 280-degree to the anti-clockwise rotation. So, during 10th week, they are herniating back to the intestinal thing. Where they are growing? They are going to the anti-abdominal cavity. Which part returns first? Jejunum is the part which is returning first. The part which returns first should be placed on the left side. That is a rule. If instead of jejunum, cecum return first, they will be housed in the left side. Remember that. But normally, the body wants the jejunum to return first and cecum to return last. That is why this jejunum settles on the left side of the abdominal cavity, the cecum on the right iliac fossa. That is why. So, this is about the physiological herniation together, anti-clockwise rotation and everything together. So, this is your short note with schematic picture and everything. You have to explain it. We stop it at this particular point and we talk about the sequel of this particular physiological herniation in subsequent classes. So, remember this physiological herniation of midgut loop and this PIL very well. So, this need to be studied well.